Hello all, I'm Aparna Bilapurkar. I am a healthcare professional by background and I have worked in healthcare over 18 years, if I remember. And I have worn a number of hats on. I have worn the clinical hat, the operational, strategic, commissioning, and so on. So I've kind of been in the system for a long time. And I do feel, as a result, I think, I do feel passionate about healthcare in general and NHS. And as we kind of celebrate 70 years of NHS. Healthcare across the world is actually undergoing really interesting change and interesting time. So while in developing world, the focus is on increasing investment to make healthcare affordable and accessible to all. In the West, we're kind of grappling with slightly different challenge where people are living longer with greater comorbidities, which obviously adds greater pressure on health and social care systems, expecting better outcomes than what we did about 20 years back, but also wanting to improve efficiencies and efficacy of healthcare delivery. So one of the ways we can address this and achieve this is by reducing unwarranted variation and waste across the healthcare system, which obviously is being talked about quite a lot in the press and in clinical groups and in management groups. And I think so. I think it's a very pertinent topic to talk about today. So this is what our topic and our theme will be today, to discuss unwarranted variation and waste. I have with me here Dr. Nahid Rana, and I will leave to Dr. Rana to introduce herself.
Hello everybody there, hi Aparna. Thank you for having me here today. So I'm a scientist and a healthcare professional. I've been working in health and science for over 20 years. I come with a public health background. I'm a geneticist, I'm an epidemiologist, I'm a statistician. So I've got a bit of a complex portfolio. Ultimately, everything I've done through academia, public health, private sector has really been to use innovative solutions to deliver and improve healthcare for the populations. My personal mission, with my public health hat on, and similar to yourself, operationally, strategically involved in systems and healthcare delivery, where I'm really, really passionate about improving what we do for patients, how we do it, how we deliver care. And there are a lot of science, health, intelligence, innovative strategies that one of my passions has been to really pull this all together and make improvements, demonstrable improvements in the system.
That's brilliant. So it's quite inspirational. So no, thank you for coming. So I guess the first question I have is really what exactly is unwarranted variation? And this is for all those people that don't quite understand really what unwarranted variation means, and lay people who don't understand what unwarranted variation is.
So we have warranted variation, which is variation we expect in a population. That happens when two populations are not so similar, so you expect differences in outcomes and services. What unwarranted variation refers to are really differences in the delivery, the processes or practices that are not explained by the population demographics, the need, the illnesses, or anything that is pertained through evidence-based intelligence. So really what we're looking at here are elements of a system that really shouldn't be there, or there's a reason that they're there. We need to really eliminate those. The term was coined by Jack Wenberg in the US, and there's a whole lot of work that's been done through Dartmouth Institute there, and a lot of work in the NHS is being undertaken over the last 10, 20 years around unwarranted variations as well. And really what we're focusing on here is the underuse of services or overuse of certain processes and services, and also variations in the quality of care. So really starting to look at the dimensions of the drivers of unwarranted variations.
So do you have any examples of what sort of unwarranted variations you've come across in practice?
Oh yeah, lots. So there's almost like tiers of variations. So if you think about it like this, in any process, in any pathway, in any decision-making process with a patient and a clinician, in a clinical practice, at every layer tier, you can have what's called unwarranted variation, something that's not predicated by the need of a service, that might not be supported by evidence-based, but it's just something that happens. So antimicrobial prescribing, you might have a practice in one area that really likes to prescribe a certain antibiotic, but actually policy says maybe you shouldn't do it so much, so another area doesn't do it. And there you go, you have unwanted variations. You've probably come across them too.
I think that's really, it's interesting, because I was thinking from my experience, I have looked at variation in processes and in clinical practices, and for one of a couple of examples that come to my mind, one of them is patients DNAing or not turning up, and how that ends up, it's a waste as well, but how even that varies across different hospitals and GP practices, and patients not turning up, how that impacts doctors' time, and they could have allocated that more effectively. But also variations across in processes where clinicians use multiple forms to move the patient across the system, and it doesn't add any value to the patient really.
And this is it. So there are layers and areas where we can all, if we started working on these different components of the system and the patient pathway, the journey, and we started identifying these variations. How do we identify what an unwarranted variation looks like? So there's a lot of work out there, there's a lot of programs and initiatives out there that look at collating data and intelligence to really start saying, well, actually, when we bring in all the disparate data across from the systems, including outcomes, community data, public health prevention data, access to services data, the primary care data, the secondary care data, community data, when we bring in that whole raft of data, pull it in, it's like joining up the pieces of a puzzle and bringing those pieces in together, saying, well, actually, when we look at the whole system and when we benchmark with areas that are like us, we shouldn't see that much deviation between the different areas, but we do. So that's the way in which we start addressing unwarranted variations and identifying them, actually. So that's identifying, then addressing. What the addressing element does is bring together those in the system who are responsible for that part of that pathway, hence that data, and really start joining up the dots and own this whole pathway, own the challenge, and collectively we encourage them to think of innovative solutions to try and resolve and reduce this unwarranted variation.
That's really interesting. So you already highlighted about data intelligence and some of the other, so what are the other components that you require in managing that and addressing unwarranted variation?
So people, engagement, clinical leadership, buy-in, the patients, the commissioners, the providers, the procurement folks, those doing the contracts. It's literally everyone, and to make something happen at scale and make sure we do it well and properly, we need to do all of this and bring all those different stakeholders, partners in at the beginning. It's something that we all have to co-own, co-design together at the same time.
That's brilliant. So how do you have examples of where you might have reduced unwarranted variation?
Yes, this is a collective approach as well, and this is a collective effort, so it's definitely not me on my own. Plenty of examples, certainly around, there was an example with C. difficile infection, so this is a hospital-acquired infection. It affects a lot of elderly patients as well. There was an area that I was working in, and all the hospital rates for C. difficile had increased, mostly in the elderly. Prescribing rates, so we thought, what is it, what's driving this? And we had some serious visits around what's going on, so we had to really think out of the box, think innovatively. With my public health hat on, we got the commissioners in the room, the nurses, the care homes, the GPs, the pharmacists, everybody in to say, right, what is it that we need to do? When we started looking at the data, there was great variations in prescribing. Now, there are certain antibiotics and antimicrobials that you shouldn't really prescribe in relation to C. difficile. It makes the patient more susceptible to C. difficile infection. when we looked across the rates of this prescribing in the patch, and it was a big patch, we had about 50 practices, great variation. And variation that could not be explained by, as I mentioned earlier, the delivery, the practices, the health needs. So we really honed into that. So we had one arm looking at the prescribing. We looked at the care homes who didn't really know what to do and didn't have processes in place for when a patient has C. difficile or potentially. Got those processes in. Got the hospital to look at their policies and really rejig it. And we created a whole forum by which we could actually say, you know, what are you doing? What are you doing? And collectively, we all contributed to reducing the unwanted variation, improving C. difficile rates within 1 year. And this is all been verified by Department of Health as well and published and presented. Within 1 year, the prescribing rates for those 4 antimicrobial prescribing compounds came down. C. difficile rates came down, and the care homes staff training was improved, and everyone was really engaged. So it was a whole systems joined up effort and approach. Ultimately, what we're doing is we're looking at the whole pathway from prevention to management to dealing with the actual crisis, and then the support outside. And what we're doing is, and you can do this with CVD, musculoskeletal conditions, all sorts of examples. But the actual beauty of this is that we all join up and come together. Now, I think you, Bapana, had lots of experience as well around bringing people, disparate systems together as well.
I think you gave a really brilliant example there of how joint working and thinking out of the box really helps. And in my previous experience, I have kind of had sort of the joy of actually working with sort of some really great leaders across different parts of the system, including public health, and to try and deal with sort of a wicked problem around, or the challenges around frequent attenders. I have to sort of say something that actually good relationships are absolutely key to this, and I think there are plenty of examples around how systems are working together to address this. So going back to the example I was giving, so there was this piece of work that we did around frequent attenders. We had already run a phase 1 of the project, which actually showed success in reducing ED attendances when clinical buy-in existed, and all the clinical stakeholders were sort of dialing in to deal with patients who were frequently attending. But there was a missing component around social prescribing. And what was interesting was we just, as you highlighted, we just joined up the dots. I became aware of a program that our local public health were kind of leading on, where they had health coaches and health champions that were doing sort of more one-to-one individual work with patients around befriending them, but also supporting them in their own homes. And this was a missing component, which interestingly, at times when we are all talking about financial sustainability and everyone is kind of looking to the pockets to kind of look at, you know, who has money, it was actually trying to really bring the system together, and I worked with a range of stakeholders to sort of see how the patient health coaches and champions could be knitted in this wider program to manage patients in secondary care who are frequently attending. And the idea was that, you know, the social prescribing element and the mental health element was brought in and closely knitted in the program. So I think it was a really a great initiative, and I think it's an ongoing program. I'm sure it has its challenges, and I just hope that it delivers. But I think there's a message that needs to go out to all systems, is to actually do identify your existing resources that exist, because there might be programs that might exist within your public health, within local authority, there might be exercise groups. How can we as health and social care partners work together to, as you said, like, you know, join up the dots and work across the pathway, right from prevention to end of life care, and actually do things really innovatively.
It's really harnessing, isn't it? It's an asset-based approach. It's not reinventing things. It's using what we already have, and that's the thing. The other dimensions of doing this kind of work is that we use what we already have. There's a lot of excellent work underway out there. There are amazing people working in the systems, patient groups as well, who really contribute to this. So we've already got, like, the people out there, and it's pulling them together into this really joined up, seamless approach to saying, how do we make things more efficient, make things more effective? And exactly as you've mentioned, there are the public health teams are out there, they're wider determinants of health, reducing inequalities, access, improving health literacy. So there's a lot around the patients as well.
So how have you got sort of examples where you've brought in patients within to kind of help with this unwarranted variation?
Absolutely. We are nowhere if we don't have the patients buy-in with this. The reason we do this, and time again at lots of shared decision-making events and collaborative workshops that we've run, I've asked the patients, what is it that you'd like to say to the system? What message would you like to portray? And time again, I convey this message. They say, I am one person, I am not bits of a system, and I just want to be treated as a whole person. So when I come to you, don't tell me that you can't tell me about my knee because you're a shoulder expert, or you can't deal with why I've got breathlessness. I want to be treated as one, especially the complex patients. And as you put it at the beginning of this conversation, we're in a situation in our time at the moment where complex needs are growing, populations are aging, the pressures on our healthcare system are increasing. So patients want to be treated as one, as a whole, and we have a duty of care to deliver that. So patients are at the heart of what we do. There's a lot of work underway around shared decision making, patient-centred care, and what we're doing now is designing and redesigning pathways so that at every point we're thinking, how could the patient, as well as get the support from the health and social care system, how can they also help themselves? What can we give them that can help them themselves? I think you were talking recently about some of the winter pressures.
Yeah. So I think that's a really interesting thought, because while we sort of talk about patient-centered care, and I know that increasingly healthcare systems and social care systems are talking about patients taking responsibility for their own health, and self-care is at the forefront. And what is interesting is now, given the fact that we will have winter pressures on and winter is coming, is there something about how we can encourage people to take responsibility of asking their GPs or going to their local pharmacists or any other centres, because I understand superstores offer that sort of service now with pharmacists. But the idea is to kind of get them to take ownership of their flu jabs, so increase the uptake of flu vaccination and also pneumococcal vaccination. So if you are over 65, strengthening the messages that actually let people take responsibility to take themselves to the healthcare professional and ask for that jab that they need.
It's a joint thing, absolutely. Isn't it now? And I was certainly impressed when my dad said to me, "Oh, it's time for my flu jab soon," and I was like, "Oh yeah, of course it is." So it's pleasing, and I think we do need to encourage that kind of turnaround so that the patient is also feeling responsible and confident with that.
Absolutely. And I have to sort of say, let's not forget all the healthcare professionals that need to obviously take their flu jabs as well, because they are at the forefront of delivering that healthcare. So, kind of reduce sickness in staff. And I think also one of the reasons for waste, I suppose. I think it's been really heartening to kind of talk to you, to kind of understand, I think, despite the challenges that the healthcare faces around financial sustainability, complex patient needs, I'm quite reassured to know that there are programs or work that exist to manage unwarranted variation and waste across the health and social care system. So it's a really positive thought. And I think we need to kind of just hold on to that, and let's all work together to think out of the box.
Absolutely, and it's been brilliant to be here today and talk to everybody listening in on us as well. There is a lot of work underway, and work's been ongoing for quite a few years, bringing science into it as well, innovation, and really bringing in intelligence and working as a whole system, because to make demonstrable improvements, we need to be joining up and doing things a bit differently, but more effectively.
Absolutely.
Yeah.
So thank you, Dr. Ranat, for coming today, and thank you to all the viewers. I'm sure you've got on your own thoughts, and I'm sure you'll have opportunities and blogs that you can share your thoughts as well. So we want to have that sort of much wider participation.
And keep up the good work.
Yeah, thank you. And don't forget your flu jabs.